speaker, let's welcome Dr. Hsien from Taiwan, sharing about hero graft experience in Chang Hospital.
Good afternoon, everybody. I'm Dr. Hsien, a vascular surgeon from Chang Memorial Hospital. Today, I would like to share our clinical experience about the hero graft. First, I have no interest conflict. In current practice, patients usually outlive their assets due to improved patients' care of the ESRD patient. The overall 5-year survival rate in this patient group is about 55%. It would be higher, above 80%, if the patient were younger. So the patients would experience multiple access creation surgery during their life. And some patients may have exhausted venous property from the upper body. So in this clinical situation, the vascular access would be recommended by newest Doki guideline for vascular access. If patient's lifespan is above 1 year, there are two choices. One is lower limb access, or the second one is the hero graft we are talking about today. There are some literatures talking about the hero graft. Most of them were mention them as the tertiary access. The hero graft had lower bacteremia than the catheter, about 0.7 to 2.7 per 1,000 catheter days. Some study, they compare the hero graft with the femoral AVG. They have a similar 6 months secondary patency, about 80%. They also share a similar infection rates about 0.6 to 0.7 per 1,000 days. They also have similar mortality rate at 6 months, about 20%. Some articles also state the access-related stale syndrome is about 6.3% caused by hero. Some case report also mention the hero would be the alternative central vein runoff for a case of the central venous disease. This is a transitional component of the hero. It's two components. One is the venous outflow component, we call it VOC. It is the silicone tube reinforced by a 19-known plate with the radial opaque mark on its tip. The second on the bottom is the arterial graft component. It had a titanium connector and a standard EBDFV graft. It takes some time for maturation, so patients have to catheter dependent from the lower body for weeks for maturation. So the manufacturer provides the neural generation that can connect to the early puncture graft. We call it superhero. So today, I would like to share our clinical experience about this neural device. The first, I have to say the proper patient selection is essential to achieve the clinical success. Careful history taking to make sure the patient there is no other catheter, defibrillator, or pacemaker leads within the patient's body. They will cause disruption during the operation. And we will do the proper muscle mapping before the operation to make sure there is no other available means for access creation. If there has, we have during the regular limb access creation. And to make sure the inflow artery is above 3 millimeters to prevent the possible post-operative ischemic syndrome. We must also to sure the patient have adequate heart function, the ejection fraction above 20%, and the adequate systolic blood pressure is more 100 millimeter mercury. The vascular entry size recommended by IFU is the internal jugular vein. The second, we must understand the accessory provided by the manufacturer. The most important thing is the 10-frame stylet and the VOC, and the RHB connector connect to the VOC, and the different size of the dilator and the sheath, and the hemostatic plug and the green clamp. They will introduce later. The following is our surgical steps. First is access to the right atrium via the original dialysis catheter or cannulate the central vein if we cannulate the central venous disease if needed. The second is explore the inflow artery and make sure again the artery diameter, inflow diameter is above 3 millimeters. And we implant the VOC the venous outflow component over the wirely to the right atrium under the fluoroscopic guidance. And we do the proper tunneling of the venous component and the graft to prevent any possible kink. And we connect the graft and the VOC with the specialized designed adapter. Finally, we anastomosis the inferior artery. As you see, we can show the surgical picture from our hospital. You can see we explore the surgical, the brachial artery first, and you can see a multiple scar from the patient's upper arm. The second goes to the fluoroscope. We retain the access through the slip tapeworm wire and gain the access throughout the previous dialysis catheter, and we implant the 20 French PLA long sheaths within the patient's body. And after the dilated removal and before the VOC component stayed in, please state a hemostatic plug to prevent possible bleeding and lethal emboli. And this is the assembled venous outflow component. It contains the stylet, and we regularly the RHB connector. And the following step is to implant the VOC under fluoroscope. It's very important to keep the wire straight in the IVC, and it must be taken. The stylet of the tip is 3 centimeters from the radial opaque marker. So make sure that everything is properly inserted. And we will check up the venous outflow component tip with the radial opaque tip and properly on the right atrium. The second, the next step, it goes on to the open part. After tunneling properly to the connection part, we clamp the venous outflow component with the green clamp provided by the manufacturer to achieve the hemostasis and prevent the damage of the VOC component. And we implant a 6 millimeter freezing early puncture graft with the standard wall to the upper arm body. We expand the graft with the graft expander provided by the manufacturer at least 3 times, recommended by the IFU to make sure the properly adapt to the adapter. And we connect the graft to the adapter. Care must be taken in this step. The graft must put in on the shoulders of the adapter. And then the next step is clamp the hinge with the index finger and the thumb. And reinforce the closure with the shutter instrument. We recommend it to line up the hinge between the surgical clamp and the adapter. And it's a very simple one to connect the VOC properly to the adapter shoulder to prevent the disruption. And finally, we anastomosis the inflow, the daily practice of we vascular surgeon. The post-operation care to give the patient is similar like the regular AV graft. We give the proper wound care and the dressing to the patient and monitor distal lymph perfusion status to monitor if any possible Steele syndrome and give adequate pain control to the patient's safety. And we also give prophylactic antibiotics orally. Last, we do not give additional anticoagulant and antiplatelet agent to patient. So this is my conclusion about our clinical sharing about the hero graft. Patient in exhaustive in venous property from the upper parts is not uncommon in modern medical practice. The hero graft would be the a reliable vascular access choice in this kind of patient. It provides a superior low bacteremia rate compared with the catheter, and it also carries a very comparative result to the femoral graft. The next point, I think that it preserves the most important thing, it preserves the patient's self-respect. The patient don't have to take off their pants or underwear during the dialysis. I think the most important to patient's dignity. In combination with the early puncture graft, we call it superhero, would be a very powerful weapon for we vascular as a surgeon to avoid the temporary catheter over the patient's lower body. And finally, the appropriate patient selection and the meticulous surgical technique were also an essential key step for clinical success. I'm Dr. Hsien from Chang Memorial Hospital, Taiwan. 谢谢. Thank you very much.